Good morning, everyone. I'm so sorry about that delay. Just a few technical issues here on our behalf. But hopefully you had some time to think about your questions before we get started in advance. So thank you for tuning in and welcome to the Denver Museum of Nature and Science at Home series. I am Kristen Uhlenbrock. I work at the Institute for Science and Policy, which is a project of the museum. We're very excited to be bringing you this COVID-19 series in partnership with the Colorado School of Public Health. We're talking about testing today. We're talking about vaccines and therapeutics last week. We were talking about modeling the epidemic in Colorado for our very first one with Dr. Samet from the School of Public Health. So as you've been following along, this would be the third week if you've been following us through the entire series, or maybe this is your first time tuning in. If you missed the other ones, you can tune in to our Facebook channel to watch those recordings, or to the Institute's YouTube channel as well. So today's topic is about testing. Testing is definitely one of those important pillars in controlling the coronavirus, as well as an important step to understanding when we can reopen. Who can get tested? How quickly are the results coming back? Is there enough widespread testing going on? What does this look like? So bringing you hopefully answers to a lot of those questions and many more is Dr. Kyle Brown. We are very excited to have Kyle with us today. Dr. Brown serves as the Deputy for Mass Testing on the Colorado COVID Innovation Response Team. In this role, he is leading the state government's efforts to expand testing for COVID-19 across Colorado. Before joining the team, Dr. Brown served as the Chief Affordability Officer for the Colorado Division of Insurance, where he led programs such as Colorado's reinsurance program to make health insurance more affordable to Coloradans. Dr. Brown served as the Policy Director for Health and Human Services under Colorado Governor John Hickenlooper. Earlier in his career, he also was a legislative assistant in the U.S. Senate, focusing on health and education sectors. He's held numerous fellowships, including serving as the Health Policy Fellow in the U.S. Senate, where he advised on issues regarding the National Institutes of Health, the Food and Drug Administration, as well as related biomedical research issues. He holds a Ph.D. in genetics, so he is very well informed to help talk us about testing. If you're tuning in today, we have two audiences, of course. We have those of you who've joined us here on Zoom, as well as our Facebook Live audience. We encourage both of you to ask questions, no matter where you're tuning in, into the chat feature, and I will try to incorporate as many of those possible into the latter half of this programming. We typically don't get to all of them, so apologies in advance if we do not get to your specific question, but we will try to get to as many as possible. Thank you again for your patience this morning. I don't want to take any more time away from Dr. Brown, and let me turn this over and welcome Kyle. Thank you for joining us, Kyle.
Thank you very much, Kristen. It's really nice to be with all of you today. I've really, such a great format and forum that the Denver Museum of Nature and Science is putting together. And I really I'm just honored to be a part of it. So as Kristen said, I've been working on the Colorado's COVID response team here for the last 2 months or so. And so what I'm going to do today is just talk through a little bit about sort of where Colorado has come in terms of testing, where we are, and where we are going. And help hopefully everybody to understand a little bit more about the types of tests and the role of tests that we'll have here in Colorado. So I'm going to share my screen while everybody is and then we'll get started. So, as I said, I'm going to be talking a lot about the sort of testing landscape here in Colorado and where we've come. Just a quick update. I think it is always important to recognize the status of the outbreak and the pandemic here in Colorado. As of last night, we were at 19,703 positive cases. Of course, we really believe that number to be much higher because many folks, especially in the earlier days of this, when there was not adequate testing in Colorado, were not being tested. We have had 3,631 total people hospitalized. The cases are present in 60 different counties, 60 of our 64 counties. We've been able to test 104,000 people. Excuse me. And the very sad part of this outbreak, of course, is that it has killed 971 people in Colorado. There have been 190 what we call sort of outbreaks, which are unique to sort of a lot of senior living facilities and other residential living facilities. So just going forward, just to talk a little bit about sort of where the cases have gone over the last several weeks. We started this all starts in Colorado right around the 1st of March. And for a while we had our first confirmed case just a few days after that. And for a while we had exponential growth in our cases, the number of cases that were being reported every day, which makes sense from an epidemiological perspective. But thanks to many of the social distancing measures and everybody doing their part in Colorado, we've been able to slow the spread. And so we haven't been adding exponentially more cases every day. We've been adding a certain flatline number, around 300 to 400 cases, sometimes as many as 700 in a day. But while cases have been growing, they've been growing at a slower rate than maybe one might expect if this were just unmitigated exponential growth. So thanks to everybody on this call for all they're doing to wear masks, to wash their hands. I saw a couple of people notice that I was sneezing earlier before the presentation gets started. So rest assured, I've been washing my hands and that it's just allergies. I want to also talk about, as our case rate has grown, obviously the growth in our case rate, and this is sort of what I was talking about in the previous slide, has been declining. So in the early days, it was growing very quickly. We were adding more and more and more cases every day. And now that we're towards the end of this, or we're out here in April, the growth rate of our cases has been declining and has slowed to around 3%, excuse me. When we're talking about testing, I want to put it in a broader context of how we are thinking about sort of controlling the virus and flattening the curve, as people say, of all the tools. So where we are now in Colorado is we're under a safer at home order, where it is generally recommended that people are staying home still, except for the most essential items. And especially if you're vulnerable, you really need to be staying home, except to leave the house to get essential items. We're wearing masks, obviously, which is very important. And testing and isolation is part of this puzzle that helps us to control the virus. This graph here talks about how testing has grown in Colorado. So that one piece of the puzzle, which is very essential, where we have gone. So in the early days of the virus, so this is the number of tests on the y-axis here that we're running in a given day, versus the day on the x-axis here. The red line is what we call the positivity rate, which means the percentage of tests that come back positive at a given time. This line is important because health organizations like the World Health Organization think that you're testing enough of your people if you're getting to a point where your positivity rate or the number of tests that you're getting back in a given period of time is about 10%. So we started there back in early March, but quickly our ability to test outstripped the rate of infections. And so our positivity rate went way up. I also want to note in this graph here that as we've expanded our number of tests, the role of the sort of public and private sectors has been changing. So in the early days, the only folks that were really able to test was the CDC, and that starts even before March 10th when we started. The CDC wasn't even allowing or releasing the assay to state laboratories until early March. And then it was very much the state laboratory that was doing the bulk of testing right in through the end of March. But as the private sector has picked up steam, more and more, the FDA has authorized more types of tests from different companies and platforms, and hospitals have been able to do testing on their own. LabCorp and Quest, which are two major testing companies in the United States, have had assays that have come online. And so more and more the green bar, which is the sort of commercial or private sector side of testing, is making up the bulk of the testing capacity. And these gray bar, or these brown bars here from CDPHE, which is the state laboratory, is actually, the state laboratory is now running below capacity for its testing. So we've had a couple of spikes in here. There's some artifacts in the data. This is really from Quest Diagnostics wasn't reporting their data for some period of time. So that happens every once in a while. So you take it more of as an average, if you will. But that's where, so we've gone from being able to barely run any tests in Colorado to we're running about 3,000 to 4,000 tests a day as of last week. And I want to talk about a little bit about, there's been a lot of talk about sort of capacity and particularly the state lab and its ability to turn tests around in a timely way. In the early days of testing, it was taking 3 days, 5 or even up to 6 days for someone to get a test result back from the state lab. And that's challenging because if you don't know someone is positive, you have to treat them as positive, especially if they're in a hospital setting, and that's resource intensive. You have to wear all the protective gear to treat them as if they're positive, whether or not they're positive or not. And so one of the things that we're particularly proud of at the state is that the state lab has been able to reduce that testing turnaround time to right around a day. And this is really around our goal right here, is 24 hours roughly. So we're doing higher volumes. Some of the high volumes that we saw, which caused such incredibly long turnarounds earlier, but are now we're able to turn the tests around in a little less, or in a little more than a day. So we've really expanded our capacity through staffing and equipment. We borrowed equipment from other laboratories in order to bring that testing capacity and the turnaround time higher. So that's, I think, part of the story is just the rapid way that we have responded to the virus as much as we can. The role of, let's talk a little bit broader. So you've seen where the virus has come, how testing has evolved in Colorado. I want to talk a little bit about the role of testing. Why do we test people at all? The most important thing for that testing can do is obviously to identify who is sick. And that helps us to know who needs to be isolated and to help stop the spread of the virus, right? Another thing that testing can do is to help identify hotspots. So where do we need to have the most resources deployed Is it a given senior living facility? Is it a given community? To focus our efforts and maybe be testing more, or be implementing social distancing measures in a particular way. And then finally, obviously, it's about protecting those who are most vulnerable. The majority of our deaths in Colorado have come from people who are particularly vulnerable to the disease, many of whom have lived in senior living facilities. So it's really important for us to get testing, be proactive about testing, so that we know when people are in danger or before the spread starts. So it's about prevention. Obviously, testing itself doesn't do much good if you don't have isolation and quarantine and the follow-up contact tracing to get the maximum sort of suppression impact. So we really have to be working on isolating and quarantining people as quickly as possible. There's two types of testing, and they have varying values. One is the sort of typical diagnostic test that is sort of the gold standard in this area is based on a swab, a nasal swab. And it tests for the presence of the virus itself. You're looking for the genetic material, you swab the nose, you send that swab off to a lab. The lab then tests for the presence of the viral genetic material using a test called RT-PCR, and then they tell you whether the person has virus or not. The second type of test is a blood test, and this is generally a blood test, and this blood test tests for not the presence of the virus itself, but it tests for the body's response to that virus. So these are the antibody tests or serological tests. So someone, if they're exposed, their immune system mounts a response, and then that response is what the blood test is testing for. This is a cartoon, so no one should take this as data, because this is going to vary based on a given virus. We don't even have a strong set of evidence yet on exactly how antibody levels change over time with this particular virus. But this cartoon is sort of the amount of a given antigen or antibody, so either the viral RNA in a person's body or an antibody that the body is producing over some period of time since a person is exposed. And as you can see in this cartoon, the thing that shows up the first, obviously, in a person's body is the virus itself. It's the RNA. And so that's what the RT-PCR test is testing for. These antibody tests are looking at these other curves, the IgM curve, which is in blue, or the IgG curve, which come up much later. And as you can tell, you can be very symptomatic. You can be shedding lots of virus, infecting other people. And these antibody or serological tests can be testing negative. So you wouldn't want to use an antibody test necessarily to diagnose someone or determine whether or not they need to be isolated, because it could give you a false negative that could actually lead to increased infection or increased spread of the virus. So we don't really know enough about how antibody tests, or what antibody tests, I should say, mean for individual patients. So if I go and I get tested for an antibody with an antibody test and I test positive, it could be that I have the virus still. It could be that I had the virus 10, 15, 30 days ago. So we don't really know exactly what it means for a person, but they are going to help us. They are helping us to build the science around understanding the disease. How many people have been exposed at some level? And so for surveillance, these tests might be very important. We don't know enough about how long if immunity happens, or how long immunity will last. Some people talk about sort of immunity passports or certificates or something along those lines that would allow people to return to work. think it's likely that people have some level of immunity, but it is difficult to sort of stake our claim that, you know, once you've been infected, you'll never be infected again. And it's, you know, we really don't have a lot of science around here. So we're trying to be cautious about that. So antibody tests have a role to play, but the gold standard, especially as we try to contain the virus, will continue to be RT-PCR. I will call out to our CU and CSU in particular, who are spearheading sort of critical research in this, in antibody testing. So as I mentioned, we run about 104,000 tests per day. We're running about 3,000 tests per day, or sorry, we've run 104,000 tests to this point in the outbreak. We're running about 3,000 tests per day. 2 months ago, we could only run much less than that, obviously, and we've really been able to add to our capacity. Our goal is to run at more than 8,500 tests per day by the end of May. We're really shooting for about 10,000. That is the level that we think that we need in order to really open the economy in a meaningful way again, and really prevent the further spread. So what do we need to get there in Colorado? First of all, we need the supplies. The supplies have been critically constrained. We need to increase their availability across the state, in sites across the state. And then we need to increase the sort of epidemiological capacity, the contact tracing that can follow up with people and their close contacts to help stop the spread. When we're talking about testing, there's a kind of key components that you need. We need for people to perform the swabbing and the testing, you need what's called PPE, the personal protective equipment of gloves, masks, the eye gear, and the gowns, so that the person who's doing the sample collection is protected from a person who might be infected. We obviously need labs. We need lab reagents so that they can do the extraction of the genetic material from the virus, and then the detection of that genetic material. We need the sort of collection kits. These are the swabs and the media that you put the little swab into. And then obviously we need the equipment, the big fancy machines, and the staff to do the testing. It's a very complicated sort of molecular test. So far in Colorado, we've been able to secure a large number of supplies, and these numbers are a little bit out of date. But by the end of the month, we hope to have secured at the state side, and this is irrespective of what our private sector partners are doing, nearly 200,000 test supplies, the swabs for sample collection, the extraction reagents, and then the detection reagents. There's 4 types or locations, I should say, where testing happens in Colorado. And we've touched on it a little bit throughout this presentation, but the private sector hospitals, so if people are being admitted to a hospital, they're getting tested, they have symptoms. Local community-based testing sites, these drive-through sites, which many of you may be familiar with. We do a lot of testing for outbreaks, especially in at-risk populations like senior living facilities. The National Guard has been helping us with that. And then we collaborate with private sector partners as well, who are stepping up. So in healthcare settings, some of the systems that have been leading the charge, Children's, National Jewish, Denver Health, have been testing from the very beginning. And then King Soopers has stepped up recently, and they've been doing testing sites in Denver and Boulder areas. They're setting up another one in Greeley and Aurora this week and next. Our local community, so you're thinking, where can I get a test? How do I know? We have a website now that lists all of the testing sites that the state is partnering with across the state. Local public health agencies are leading the charge and working with their health facility partners. There's a website here that I've listed, and on that map, and then we now have a map of all of the testing sites that we're working with. This is not comprehensive. It's not the entire universe of places that are doing testing, but we've got sites, at least I think over 40 sites across the state now. Some of them overlap on this map, so it's a little hard to count. So. And then we're working with our local public health agencies to test for outbreaks. There have been outbreaks in Weld County and other places. This helps us to control the spread, especially in these vulnerable populations. And then I'm sort of flying through the last parts of my slides, so I apologize about that. But we've been able to partner with Colorado State University to test for not just the residents, not just symptomatic people, but all the workers and all the residents at senior facilities. We know that many people who are infected with the virus have no symptoms at all, show up to work, they get tested, they get their temperature taken, they're fine, and so they have a real risk of spreading the virus to other places. And so we're expanding our work with Colorado State University to make sure that senior living facilities, we're testing every worker periodically, once a week, to make sure that they're not spreading the virus. Who can get tested right now? In the beginning of this whole outbreak, there was such limited testing that really it was only about symptomatic healthcare workers and symptomatic inpatients. And now you can see this list this week is really expanded the number of the people who can be tested. So if you're symptomatic, I would encourage you to go to the community testing site in your area, seek out a healthcare provider. And then as I've mentioned, we've been able to expand more of our testing in these high-risk facilities, testing even people who are asymptomatic, so that we make sure that they're not carrying the virus and spreading it to others who are more vulnerable. So part of this, I want to touch just briefly on some of the infrastructure that's necessary. I mentioned that testing is really only one part of the puzzle, and a key part of testing, making testing effective, is having the epidemiological infrastructure, the contact tracers in place to isolate and contain folks who've been exposed. And so the state has been doing a lot to step that up. We've doubled our epidemiological and contact tracing team in the last 2 weeks. And we're building a COVID navigator program so that people who are in isolation, by the way, this can get the services that they need, I should say. And the work that we're doing to expand contact tracing is going to grow, probably orders of magnitude over the course of the next couple of weeks here. And some of that will due to the reliant on the state budget. We're also doing some new and innovative things so we can sort of predict where outbreaks might be occurring. We now have a symptom tracker. So if you think you have symptoms, I'd encourage you to go onto this website, check, see if you might be a good candidate for going and getting tested. And we can use that data along with data from the searches that people are using in Google to tell us where there might be emerging outbreaks. So with that, I just want to thank everybody for continuing to do their part to slow the spread of the virus. Obviously, wearing masks in public, continuing to socially distance, and wash your hands is going to be a huge part of how we slow the spread of the virus. And then just remember that we're safer at home, and that we're all in this together. So thank you very much for the opportunity to speak with you all today.
Thank you, Kyle, very much. Very informative presentation from my behalf, as well as I'm sure everyone else tuning in, because we're getting a ton of questions for you. So let's start off with a little bit that you were talking about with some of the early challenges to testing, how we've scaled up to currently our hopes for the end of May, which you said was at least 8,500 per day, if not 10,000 tests per day, right? It looked like some of the challenges are related to supply. Is that accurate? Like what has been that challenge over time, and what do you see as our current and future challenge to get to that high level of testing?
Yeah, supply, I would say, was that there's many barriers along the way. And even in supply, there are many supply chains within the testing that have been sort of broken. As I kind of alluded to, there's really kind of three parts to the test, to the diagnostic test, right? You go and you collect the sample with a swab, you extract the genetic material, the RNA from the virus, and then you detect it, right? And you need specific supplies at each point in those three steps. So for a while, we didn't have any of it. And then at various points, we've had, this part of the supply chain, the detection reagent has been broken, or swabs were really hard to come by. And so we've been seeking, part of what my team has been doing is not only thinking about the strategy of testing, but also about how do we alternatively source some of these supplies. So we've looked outside the United States, we've looked inside the United States. Supply chains are beginning to open up, but we've been able to bring hundreds of thousands of testing supplies to Colorado over the course of the last, really the last month, I would say, finally. But that's been a critical constraint. We've always said that we've had the machines and the people, but we just haven't had the supplies. So.
Okay, thank you. And for that 10,000 or that number, are we talking about specifically the swab test? That's maybe a clarification, or blood test, or a combination of both? What's that number?
No,
and then maybe, go ahead, yeah.
I was just gonna say the 10,000 a day is the swab test.
Okay.
At this point, I think the antibody test, the blood test is really something that we'll need to sort of augment. I think its primary use case at this point is sort of epidemiological. It will help us to understand which communities have been most affected by the spread of the virus. But from an individual perspective, we're still trying to sort of wrap our heads around how that can be most useful. So 10,000 a day PCR tests.
Great. And what about saliva tests? There's been a lot of questions around that, and at-home testing kits. What are your thoughts around that type of testing?
So I think this is really promising technology, and there have been EUA's authorizations, I should say, from the Food and Drug Administration for saliva-based tests. Some labs have been able to validate it. A lot of I think the gold standard that a lot of doctors and laboratory folks would tell you is still the nasal or nasopharyngeal swab. But it's a really exciting idea and an exciting thing that a lot of people, I think it's getting to be more common. We at the state, part of our overcoming the supply chain issues has really been about exploring any number of different methodologies. I mentioned the King Soopers sites. Those sites are using not a full nasal pharyngeal swab, which goes significantly back into your nasal passage, but it's more like it's more anterior. It's a little closer to the front of your nose, and it's actually a self swab. So the person drives through, they hand you the testing kit, and then the person can swab themselves, and then hand it back to the nurse practitioner. And that's a method that seems to really reduce the amount of personal protective equipment that is necessary, because people, they only need to crack their window like this much to get you a test kit. They don't have to like open you and open the window and do the full swab. So there's a lot of new and innovative approaches that are helping to bring testing and make testing more broadly available. And I think saliva is going to be a big part of that. So.
Right. If you don't mind, can we go a few extra minutes since we got started late? There's so many questions and I want to try to get to a couple more. Okay, great.
I'm fine.
Could you maybe briefly explain to folks what false negative and false positive is? And then how does that rely into kind of the validity and the accuracy of testing? There's a lot of concern around tests being not accurate, points and measurements. Yeah.
So I think that, so false negative is, I'm a patient, I have COVID, I go in and get tested, and it comes back negative. So the test is telling me falsely that I'm COVID negative, even though I'm positive. That is a very significant concern from a public health perspective, because that person might now has been told, you're fine, go out, you know, socialize, be with your friends, lick doorknobs, whatever. And you shouldn't be, right? You should be isolating and staying at home. So very concerned about false negatives. The challenge with any testing is that there will be some false negatives, I think. The lower, obviously, especially in the early days of infections, with an antigen or a PCR-based test, right? The SWAB test that we've been talking about. It depends on the viral load to some degree at any given point in your infection, but the rates are, you're much more likely to test positive from that. The false positives, I think, are problematic from a sort of societal kind of, we're isolating people potentially that we don't want to, right? A person goes in, is negative, goes in, gets a test, is told they're positive. I don't know that this has been studied as well. I think some of the most interesting false positive work is related to, can people be reinfected? And there have been these cases out of South Korea and other places where, you know, there's the concern that people have recovered and then they get another test maybe 2 weeks later and they test positive again. And the concern was, oh, they've been reinfected. And now the thinking is maybe it's just residual virus, residual genetic material from the virus that's causing the test to come back positive. So you get into this question of immunity as well. But I think that false positive result is probably concerning from we don't want to be locking down people or telling them to isolate who don't need to be. Whereas false negative, it's really concerning from a disease spread perspective.
Could you talk a little bit about how testing can and will and should be used to both determine how we reopen or how we potentially close our state here?
Yeah, I think that when we're getting, so testing, the level of testing is sort of needs to be dictated to some degree by disease prevalence. And I talked about that sort of positivity rate and this recommendation by the World Health Organization that we need to get to a positivity rate of around 1 in 10 or 10%, right? So if we think that we have sufficient testing if only 1 in 10 samples is coming back positive. I think that, you know, we want to be cautious. If a lot of people are coming back negative, you want to be cautious because you want to, you know, someone who tests positive or tests negative today could come back and test positive tomorrow. And especially in vulnerable populations, you know, that asymptomatic spread can be really, really dangerous for folks. Until we have better understanding so I think testing is about controlling the spread, and in many cases allowing those facilities with vulnerable populations in them to continue to operate and prevent outbreaks. For the broader population, I think testing is knowing that we have adequate testing, will allow us to, and that we have adequate contact tracing, will allow us to know that we're able to identify cases really early, and then, you know, isolate them, quarantine them, so that we can potentially prevent the spread, and keep things open. I think the future of this is less about shutting down the entire state, as we've had to do so far, but building infrastructure such that when we have an outbreak, or people start to test positive, we can shut down maybe a business or an area, maybe even a community, but not the entire state. So I think that's where testing and contact tracing really come in. If we're testing at an adequate rate, then we will know quickly when those outbreaks are occurring. So.
Thank you. Let's wrap up with one final question about coordination, right? Coordination from the local, state, and federal levels, as well as Colorado with other states. What are you seeing as coordination, really your hopes for better coordination or whatever? Could you just speak a little bit to that and how that's going to help us, or how we're going to go at this alone?
Yeah, I think from the state perspective, we've really been trying to focus on coordinating well with our local public health agencies. You know, the way, you know, Colorado is really a local control state, and our infrastructure is built around local communities, and that works really well for folks. So we as a state, in supporting testing across across our communities, are about, you know, we've gone out and bought a bunch of supplies. We have SWAB kits. We have PPE, or gloves and masks and gowns and things. And we have technical assistance, so we know how to run sites. And so we've been distributing those supplies and information to local public health agencies and their partners across our state, coordinating with them. You know, we have data systems across the state. Many local governments and local communities are really at the forefront, you know, adding contact tracers, developing technological solutions which are innovative. So we're really hopeful to be, we are really excited to be working in partnership with them. You know, from the federal government, obviously there's been some bills that have passed. We're hoping to see some of that money soon. Testing is not cheap, and we need support from the federal government in order to make it happen. I think, you know, we have not felt like there has been a strong federally coordinated response, but we have been very fortunate to work with with our local federal delegation really closely and in partnership, and they have been really, really helpful, our senators and representatives. And so I think that we're all trying to work together in the best way possible. So.
Thank you. And thank you to everyone who tuned in, especially a big thanks to Kyle Brown here with our state for all that you and your colleagues are doing to keep us safe. We applaud you. We wish you the best, and let us know how we can be of help to you. We know your time was very precious, so we thank you for spending your morning with us, and thank you everyone for tuning in and for being patient as we got started a little late today. Just a good reminder to everyone, this series is ongoing. Next Monday, same time, we'll be here at 8:30 a.m. having our next talk, which is going to be a little bit on stories from the front lines, where we have two medical professionals joining us. We have Mark Moss, who's from University of Colorado School of Medicine, as well as Tracy Preeb, who is a charge nurse at the medical ICU at the University of Colorado Hospital. They're going to be joining us talking a little about those first-person perspectives of what they're seeing in their line of work. Again, big thank you to Colorado School of Public Health, especially Dean Samet, for really instigating and helping us keep this series ongoing and vibrant. I know he is participating in a virtual graduation today with his students, so congratulations to all of you that are graduating. I do want to take a moment to thank everyone of my colleagues here who've been helping to make this series go on. As of course the saying goes, it definitely takes a village. So I want to especially recognize and thank Trent Noss and Nicole Delaney, who work with me at the Institute, as well as my museum colleagues, Alyssa Carlson, Kim Evans, Tanya Breeling, as well as Julia Spalding-Beagles, and all my other museum colleagues who really make this series possible. We're conducting a survey. We're going to drop the link right now in the chat for you because we want to hear your feedback on topics for future webinars. So it's going to have a list of some ideas we've come up with, as well as a place for you to enter in your own ideas for topics that you want to hear from. This series really is for you, so we want to really know what you want to learn about, and we'll try to make that happen. You're going to find a recording of today's webinar if you want to go back and reference Kyle's slides or share with someone you want to know. You can find a recording on our Facebook channel, the museum's Facebook channel, and then you can find also a recording on the Institute for Science and Policy's YouTube page. We'll send all this out in an email link follow-up, as well as a link to the survey. We encourage you, of course, you to follow us on social media. The museum is at Denver Museum NS. On Twitter, the Institute is at Institute Cy Paul, and the Colorado School of Public Health is at Colorado SPH. So thank you all for joining us today. We do encourage you, if it is within your means, to consider making a donation to the museum. You can text the donation. You can text DMNS at 51555. We'll have a slide that comes up here when I'm done talking with more information. Thank you all to our frontline workers and our medical professionals, as well as all of our leaders who are trying to work to make us safe. And thank you to our museum members, donors, and of course, all of you viewers. I hope you have a wonderful rest of your week. Thank you for tuning in this morning.